Welcome. My name is Shelley Gladstein, and I'm the host of Osteo Boston. And I just want to say I'm excited to have so many Osteo Boston members on tonight, as well as the Osteoporosis Foundation of New Mexico. And any of you that have just recently joined, I want to welcome you. I have forgotten to mute everyone, so I'm going to mute everyone and then unmute if I've told you. I want to welcome our everyone that is participating tonight as well, and thank you for doing that. We're going to be hearing from you, and I'm excited to learn a little bit about you. Thank you for being so revealing of your own history for educational purposes tonight. And I think we're going to learn a lot. I'm pretty excited to have Justine Bernard here. Dr. Justine Bernard, we're going to hear about her in a minute. I want to say, if you're listening on YouTube, I'm excited to have you. If you like what you're hearing tonight, give us a thumbs up, or, at best subscribe, and that way you'll get notice of new programs. Thank you. Anyway, I'm going to bring up Diane, who's going to introduce our speaker.
Thank you, Shelley. I'm pleased to introduce Dr. Justine Bernard, and this is what we'd like you to know. Dr. Justine Bernard moved to New York City after college to dance professionally, and during this time, she started teaching the gyrotonic method. After working with many therapeutic clients, she decided to return to graduate school. In 2003, she received her doctorate in physical therapy from Columbia University and later worked in major New York City hospitals. She then moved back to Washington, D.C., where she opened Elements Fitness and Wellness Center. At Elements, Dr. Bernard incorporates her experience as a professional dancer and gyrotonic and gyrokinesis master training into her treatments. In combining the gyrotonic system with her knowledge of physical therapy, people can transform their bodies from moving with restriction and caution to moving with freedom and joy. Dr. Bernard has specialized in osteoporosis and bone health since 2008, and she has consulted with hundreds of people with osteoporosis. And as a master trainer, she travels the US and the world, educating gyrotonic trainers on how to work with people who have osteopenia and osteoporosis. She has a great passion for bones and truly enjoys empowering people with bone strengthening and education. Turning it over to you, Justine.
Thank you, Diane.
Hold on a second. Okay.
Thank you, everyone, for coming tonight. And thank you, Shelley, for having me. So I think we'll dive in. I was speaking with Shelley when she asked me to present here, and we thought that it would be very helpful to show what a physical therapy consult would even look like, and also how I design exercise programs for people with osteoporosis based on their consultation. So we have 3 wonderful volunteers. We actually had 11 volunteers. So thank you, everyone. I spent about an hour with each person, and it was very difficult to pick 3 out of these 11 fabulous people. I just wanted to try to find 3 people that represented as many people as possible. So we had 11 people ranging in age from 49 to 81, and T-scores were from 0.6, so positive 0.6 to negative 4.0. So we had a large variety, and I did try to pick 3 people who represented many ideas and things like that. So I would like to start with Laura. I'm going to share my screen, and please keep in mind that this consult was uniquely designed for this individual, for each individual. I do want you to learn from it, but take it with knowing that it was designed for this one person. Actually, we can start with Karen. You want to start with Karen?
Oh, okay.
Or Laura.
Okay, we'll start with Karen.
Karen? Okay, I'm gonna share my screen.
Oh, wait a minute. Hold on a second.
I'm
Oh,
happy.
there we go.
We're gonna start with Karen.
Okay,
Yes? Okay.
yes.
All right. So hopefully everyone can see me, Karen, and the screen. Zoom is technology
Yes,
is not the best. Okay, thank you.
perfect.
All right. So I just wanted to go through the quick screening. So Karen is 55, menopause age is 48. So I tried to pick, we have one person who's not in menopause yet, one person who's in that 5 to 7 years post. So that's when the biggest decline happens or decrease in bone density, where estrogen affects the bone the most. And then we have someone past the 7-year mark. So that was one decision I made on who to pick. So first I have age, I have year, age of menopause, then any additional fractures. So for Karen, she has no previous osteoporotic fracture, but she did have a spine fracture as a teenager. Family history, her mother had osteoporosis, but no fracture, and she has a brother with osteoporosis who had a fracture. No medications that affect bone. Then we have the T-scores. So this looks a little bit like a jumbly mess, but I tried to separate over here on the right is her current scores. So the other scores just give me an idea over time what's been happening. So you can see in the bold, the T-scores, we have spine, femoral neck, and total hip. So these are the highest fracture sites. We also tend to have fractures in the wrist. And you can see over on the right, spine is minus 1.6. So that's an osteopenia T-score, not osteoporosis. Femoral neck, we have left is minus 2.2, right minus 1.7. Total hip left is minus 2.9 and right is minus 2.3. So if you want to follow along, if you want to grab a piece of paper and a pen, you can do this for yourself, right? So we have what's your age? When did you go through menopause? Do you have additional fracture risks, such as family history or a previous fracture? Any medications that affect bone, you can write those down. Then you have your T-scores. So for Karen, we're going to focus mainly where the osteoporosis is, which was the left, I have highlighted here in yellow, total hip left. So we're going to keep that in mind as we get to the exercise portion. Then I have some follow-up questions. So I like to see the actual DEXA scan with the images if possible. For the spine, we have to be a little bit concerned isn't the right word, but with the data, if someone has scoliosis or severe arthritis or any spine surgeries, I tend not to use their spine scores as much when thinking about exercise. Then I ask for any other diagnostic tests that they may have had. So again, you can fill this out for yourself if you want, if it's helpful. Then I go into exercise concerns. So what are their strengths and what are their weaknesses? So for Karen, she has exercised for many years. She does light weights and stretching. She walks 2 to 3 times per week, about 2 miles. That was her prior. Currently, she's still doing light weights and stretching, and she walks a little more now, so 3 to 4 times a week, and about 2 and 2.5 miles. So those are great. That's if someone already exercises, sometimes it's a little easier to continue with that and progress that. But what are the limitations? What are the barriers? So osteoporosis in spine, the negative means she does not have osteoporosis in her spine, which is wonderful. So if someone has osteoporosis in their spine, we're going to have more limitations on what type of exercises we may incorporate. The other one would be less than, so more negative than -3 in the femoral neck. So if someone has a -3 in the femoral neck, we're going to be a little more careful with impact. We're going to do it a little more gradually. But other things we have to be concerned with is there was that low back fracture at age 18 with basketball, and she was put in a brace during those peak bone building years. And then she does have a low back injury that can flare up. And she mentioned in the consult that she was doing some arm raises. We call them lateral arm raises with 2 pounds. And that did flare her in the past. So right away, I'm starting to think about, we're going to keep the weight closer to our center of gravity and not too far away from the center of gravity. All right, so then movement motivation is super important. So this often I determine kind of level of supervision. What does that mean? So some people are very motivated to exercise. They've exercised their whole life. They're very motivated to increase their bone density. They enjoy exercise. These are all big positives. So some people, when we discuss at the end of their program, whether they want to see me twice a week or see me twice a year, right? So if someone's not very motivated to exercise, they may want to see me more often so that I hold them accountable for their exercises. Or they might want to join more of a group class where people will help motivate them to exercise. So that's why I ask about motivation. All right, so based on that consult, these were some ideas we came up with. So we have to, every osteoporosis exercise program needs to incorporate 3 things: balance, impact, and strength or resistance training. Okay, so this is also a time to think about what you're doing in your current exercise program and how you're going to incorporate strength training, impact, and balance. And we're going to talk more about each one. So with Karen, as I mentioned, we really want to focus on strengthening the hip. So it's I see people with osteoporosis every day. And so last week, there were 4 people who brought up feeling a little bit overwhelmed with their program. Now, it may have been the holidays, but I like to focus on 1 or 2 things. And so for example, one person last week, I said, listen, this is your 3 exercises that I want to make sure you do at least 3 times a week. If everything else goes out the window, don't worry about it. Focus on these 3 exercises. So that's an example. So for Karen, the biggest thing I want to focus on is that total hip score and getting her lower extremities as strong as possible. Okay, so what did we start with? We started with rows with a TheraBand. So will TheraBand exercises increase bone density? That depends, right? For Karen, she's already strong and she's already doing light weights. So most likely the TheraBand alone will not increase her bone density, but we're going to start there because we don't want the flare up of the back. So we're going to start with a gradual progression, a little slower than I might do with someone else who's already lifting heavier weights, as we do not want to flare up the back. So we started with 2 sets of rows, 3 times a week. We'll get into this a little bit more in a moment. Then the hips. So the hips I have a little star here. We're going to do squats with no weight to start. And then for the first warm-up set, then she's going to go on to a second set and carry the 3-pound weights. She's going to progress quite rapidly to 5 pounds, but eventually over time, we're going to add about 1 or 2 pounds each time, and she's going to pause at about 10 pounds. So I had the pleasure of working with Karen for an hour, and then she also followed up with me, and I learned that she's been progressing her weights, and I'm very excited about that. Now, the 3 fracture sites I mentioned are back, hips, and wrists. So even though she does not have a DEXA scan of her wrist at this time, we are going to do some wall push-ups and some planks because that is weight bearing into the wrist. Okay, so if you remember, her total hip score was her lowest score at minus 2.9. So we do want to work on femoral neck as well. And the best way to improve femoral neck scores is through impact. I did mention at -3 T-score or more negative. So a lower score, you want to do that quite gradually. So what we did is Karen's already has a great walking program. So we just had to intensify that a little bit. And we added faster walking 1 minute of every 10 minutes. So I'll go through that again. For balance, Karen's quite young. Her femoral neck T-score is good. So yes, we're going to work on balance, but it's not going to be a priority at this time. Things we did work on is reviewing her current exercises, so what she's doing now. And the educational part was that I recommended taking out, she had a deep twist on her back, and that we call end range passive rotation, and that can be a risk factor. Now, it also makes her back feel really good. So I did not emphasize this risk factor too much because, again, she does not have osteoporosis in her spine. So I'm not so hardcore on this. If it helps her back, we can negotiate and maybe find something better, but she did take my advice and she has taken that exercise out. Just an additional note that I want to be mindful because this is her second session, is she had a question about working up over the next several months. How can we do that safely and what is a goal? So that is a summary of her initial consultation. And then what I'd like to do is jump on over and then we'll switch. Again, I usually do this in an hour and we're trying to do this all in 20 minutes for each person. So I might be going a little fast, but I'll repeat some stuff. So Karen, how's it going?
Good, thank you. Thank you,
Good.
Justine.
So I would like to ask you, we definitely want our full body resistance training 2 to 3 times a week. Because I'm starting a little bit lighter with Karen, I don't want any flare-ups. I'm suggesting more of a 3 times a week. So Karen, what days are you doing your resistance, your squats and things like that? What days have you picked?
Well, I was doing Saturday, Sunday, Wednesday, but I know you said it's probably better to space it out, right? Yeah,
Yes.
so I'm kind of transitioning to Monday, Wednesday, Friday.
Excellent. So this is our perfect world chart. So we're gonna say Monday, Wednesday, Friday, you're doing your squats. All right, and then you're also gonna do your rows. So this is just a quick, what I call a cheat sheet, right? So all the details of how she does her rows, we are emphasizing that she does we call it an abdominal draw in, so that her abdominals are very active and her alignment is good. So we reviewed that rows. And then she's also going to be doing her wall push-ups and her planks. So this is for the osteoporosis program. She also does some great stretches. I cleared all those. She's going to keep doing those. Some of them we put as warm-ups. Some of them we put as stretches she can do when she wants. All right. So in general, we have squats is for her hips, rows is for her spine, push-ups and plank for her wrists. And what I would like to do is focus on the progressive overload or progressing the amount of weight for her squats on this session. So she's going to build over the next couple weeks up to 10 pounds. So that is still quite light for her because she is fully weight bearing. So at this point, we may not be building bones still yet, but we're going to work up to it. And my goal for her over the next 6 months would be to work up to 24 pounds. So that would be 2 times 12 pound dumbbells. Okay, so we're gonna work up to that over the next, I'm even gonna, over the next 3 months. Okay,
Justine,
yes,
I know what a squat is, and maybe everyone does, or maybe everyone doesn't. Can you just give us an idea of what a row is?
Very much.
All what these exercises are that you're talking about?
yes, absolutely. So, let's go through this. I'm going to stop the share for a moment. So I'm stopping the share so you can see me more. And Karen, are you up for doing this with me?
Sure.
All right. So a squat, another way we call a squat is a sit to stand. So a squat exercise would be on 2 feet. And you're gonna sit nice and low as if you're gonna sit into a low chair. You're gonna be mindful of your knees, ankles, everything like that. You're gonna draw the abdominals to the spine with a nice flat back and stand up. And that's from the side. So a squat, you're gonna sit down with a nice flat back, abdominals are drawing in. Sit as low as your ankles, knees, and hips allow, and then stand back up. So if you're gonna do that with weights, here I have 2 weights that I'm holding, and they are going down near my legs. So what I'm not doing right now, this is more of a deadlift, which we would work up to, but we're not doing it with Karen today. But I connect my shoulders. So if the weights are further away from my center of gravity, it's gonna be more load on the spine, which can be positive or negative depending on what your body wants, right? So this is why I chose for Karen a squat at this time until I know her abilities a little bit better. All right, so now I'm gonna demonstrate a row. And for Karen, we decided on 10 repetitions because again, it's a lighter weight. Let's see, there's my mirror here. Oh, that's a little hard to see. So a row you can attach to a doorknob, and I like to cross the band, wrap around. Do you have your doorknob all set, Karen, or not?
I do, but I can't really do my camera with it. Sorry.
Okay, Debbie has it set for her session, so we'll go through rows again. But a row, step back enough that you feel a little tension, right? So if you're too close and your elbows are already by your sides, you're not gonna feel any tension. Take a nice step back, feel some tension on the band, shoulders roll back and down, abdominals pull into the spine, and then you just row like you're rowing a boat. And these are upright rows here. So I'm standing upright. So that's a row, a squat. A wall push-up would be a push-up on the wall. And then a plank is on the floor. Pull this forward. I know I'm going fast, but we can do more on this another time. We can have plank on a wrist or plank on a forearm. I sometimes start with the forearm. We can also do planks on the knees. But to build bone density in the wrist and to have some weight bearing into the wrist, I graduate to the wrist eventually. I have a whole program that I do to build up to the wrist. So that was a very quick down and dirty of those exercises.
Great.
I am going to share the screen one more time because I really wanted to help people design their own exercise program. We had a huge variety. We had, one of the volunteers is 64 and squatting her full body weight, so squatting 135 pounds plus her own body weight. So we had a huge span. Is really wonderful to see. And we have someone who's never really exercised before. So I know this can be a little bit overwhelming for someone who might not know all these exercises, but I wanted to focus a little bit more on how you can design your own program, trying to make it as simple as possible. So for Karen, she's already walking. Karen, what are you up to these days for walking?
Well, I know you said I don't have to do it every day, but I walk every day. Between like 2.5 and 3 miles.
Great. So you're walking daily. And that takes you about how long?
It takes me 55 minutes to do, it's like 7,000 steps, which I think is like 3 miles.
Yes. Okay. So she's walking daily. Have you added that brisker pace for a minute?
Yes.
And how many minutes are you up to?
I'm only up to a minute. I only
That's
do it for a minute. Yeah.
Good start. So 1 minute fast. So there's several ways to approach bone density with walking. In general, walking will increase bone density if you're going at what we call 85% heart rate max, which is quite intense for walking. So what I tend to recommend is 1 minute of fast walking for every 10 minutes of walking. What does that mean? You walk 10 minutes, you walk 1 minute fast. You walk 10 more minutes, you walk 1 minute fast. So you're going to gradually build one. So for Karen, again, I just met her for an hour. So I said, let's just start with 1 minute of fast. But if that all goes well, she said her back is fine, everything feels good. So then I'm going to add another minute. So she's going to do 10-minute walk, 1 minute fast, 10-minute walk, 1 minute fast. So that now she's up to 2 minutes of fast walking. So I'm going to do 2 minutes. And maybe for now, we're just going to add that 3 times a week, the faster pace. Okay, so and why fast? Fast is going to increase the velocity and increase the impact into the bone. So that's why it's kind of like throwing a ball. If you throw it softly, it just bounces softly. If you throw it hard, it bounces back hard, right? So that's the ground reaction force into the bone. So that's why that's all we're going to add for Karen at this time. There's many other ways to change this, right? She could walk the same distance in a shorter time. So that would be another option. You want to be careful of a tendonitis or shin splints or anything like that. And then I'm not going to go through balance with Karen because it's not a priority right now. And we'll talk about it with Debbie. Okay. So that is we're focusing mainly on total hip and some femoral neck. So total hip, we got our strength training, and femoral neck, we have our impact.
Can I ask you a question?
Yes.
The 2 minutes of fast walking, it's you want me to do 1 minute of fast walking every 10 minutes and do that 3 times a week?
Yes.
So that'd be more than 2 minutes, right?
Only for 2 minutes at this point. So
okay.
Yeah, so try that for, I'm going to just say 2 weeks. Try that. As long as your shins feel good, your ankles feel good, everything feels good, you could add, after 10 more minutes, add the 3rd minute.
Okay.
Just like you're doing with your weights.
Got it.
Yeah. So
Thank
every
you.
2 to 3 weeks, you could add, if anything's kind of irritating you, back off and then try again. All right. How long that we have some good questions here. How long should the plank be? Again, I'm going to focus a lot with Karen on her form. So if I see any arch or a dip in her low back, we're going to back off. Yeah. So form is very important. Karen, how are you able to progress 1 pound a week with your weights? Do you have one of those ones where you stick the weights in, or do you have a large set of weights?
No, I only have 1 pound, 2 pound, 3 pound, and 5 pound weights. So I'm going to have to eventually buy heavier weights.
Yes. So this is something else I discuss is what toys, what weights, what do you have in your house that we can start with? And then once we get a baseline weight, then I'll ask people to invest in more stuff. But initially, I want to get people to as much as we can with body weight and with whatever you have in your house. And then once we get you to that strength point, I'll have a better understanding of what you should actually purchase. So what I'm going to ask Karen to purchase eventually is a 10-pound weight and a 12-pound weight, and then eventually 2 10s and 2 12s. So that would be what I'm going to suggest. Not
Great.
quite yet,
I guess
but
Just,
to answer the question, I guess what I plan on doing is holding it close to me instead of 2 on the side. I'd hold like a, I'm doing 5 pounds now. So next I'll hold the 1 pound and the 5 pound together close to my body. I guess that's kind of answering the question better. Maybe, I don't know.
yeah, no, that's perfect. That's perfect. Yeah. So that's what she's doing. And then eventually, so the rows are going to help me teach her how to hold the weights in a way that's more connected to the body and not that dangling the weight like we did with the deadlifts. So,
one
all
more
right.
question, Justine, that someone asked that I thought was great was
Yeah.
how many reps per set on squats, rows, and push-ups, and how many seconds per plank?
Yes. So for Karen, I'm starting her because the weight is light right now. I'm starting her with 10 reps.
Mhm.
And the reason I'm doing 10, we need to build the weight. And you guys have probably, many of you have heard about the Lift More study. So the goal with that would be 5 reps, 5 sets. Now, 5 sets for many people, it's a lot of time, it's a lot. So I tend to do a warm-up set with a lightweight, and then 4 sets this is what we build to, 4 sets at a heavier weight. Right now for Karen, I'm just doing 2 to 3 sets, 10 reps. So we're working closer to a 70% 1 rep max, and we will get her to 85 1 rep max eventually.
Awesome, thank you.
And I think I answered the plank question, but I can.
Mhm.
But we are gonna go now because Karen, do you have any questions before I move on to Laura, sorry.
The plank I've been holding for like a little over 30 seconds. I suppose I could work up to like a minute slowly, right?
Yes, yes. So you're starting at 30, but I would check your form just because of the back. And you're on your hands, correct? Or on your
I'm
elbows?
on my
Elbows.
what do you call this? My forearm. Yeah.
Forearm. Okay. All right. So we would work up to hands and up to a minute. And then most likely I like to vary. Once you get to a minute, I change it and make it harder. So that means you can add a lifting of an arm, lifting of a leg, adding some resistance and some weight to that. We can also add some rows to that plank. So, and we add also walking on your hands in a plank, which is a very fun exercise. So we'll have to have another time where we do all the exercises. But I did want to get through the 3 volunteers. And then what I'll do at the end is I can go through more of the exercises and exercise questions.
Thank you, Karen.
Yeah, thank you so much, Karen.
Yeah, so
Thank you.
wonderful.
Thank you very much, Justine.
Yeah.
I appreciate it.
My
Awesome.
pleasure.
And hello, Laura.
Hi, Laura. Thank you for volunteering.
Oh, wait a minute. I've got to bring you up, Justine. Somehow that
Oh.
ticked you off.
That's okay.
There
I'm
we
going to
go.
share my screen anyways.
Okay.
And I'm going to go to Laura. Okay, so Laura is 49 and she's premenopausal, so she's not in menopause yet. And then what are her additional risks here? So usually we say additional risks are anything other than being white or Asian, thin, white or Asian, postmenopausal and female. So the three typical risks. Yeah, so any additional risks to that. So family history, both parents have osteoporosis and her father fractured his spine. And the mother may or may not have had a fracture. We're not quite sure. 2 pregnancies. Laura has not had a previous fracture, and that would be an osteoporotic fracture when I talk about fracture. She did have an eating disorder at age 18 with amenorrhea. So she had loss of her menstrual cycle. And the building years is all the way up to age usually about 25. So these are some of the peak bone building years that Laura missed out on. And she also ran for weight loss. So any excessive endurance exercise can be additional fracture risk for osteoporotic fracture risk. And also lightweight. She's not taking any medications that affect her bone at this time. So those are the risks. And now we're moving on to the T-scores. So the date of her last DEXA scan was January of this year, and her spine was minus 4.0 T-score, femoral neck minus 3.1, and total hip minus 1.9. So the DEXA scan concerns, she does not have arthritis, scoliosis, or any fractures. She has not had any other tests, but I'm very happy to hear she did a follow-up email with me, and she met with another medical doctor who specializes in osteoporosis, and she ordered some additional testing. Right. Strengths. She has done prior exercise, including online bar classes. And currently, she did CrossFit, but then when she got her osteoporosis diagnosis, she stopped. She runs 1 to 2 times a week, about 3 miles. And she updated me that she can now do 10 pull-ups, which is pretty incredible. All right, so movement limitations, barriers to exercise. So Laura does have osteoporosis in her spine. So when someone has osteoporosis in their spine, minus 2.5 or more negative, or lower, we do want to avoid rounding the spine. And we call that flexion. Some people refer to that as curling or rounding. So that's something we're going to be mindful of. Also, she does have greater than, or sorry, I should say less than. This should be a less than sign, not a greater than. It's less than minus 3 in the femoral neck. So we need to be a little bit careful about how we progress her impact. Don't want to stress fracture. All right, so she is very motivated to exercise, and she's exercised again throughout her life. So that's also another positive. And we're just going to work on building bone. So if we do a quick summary of this whole thing, what are we most concerned with? Most concerned with spine. So in general, spine, I like to say, is the first to go, but the first to grow. So often, for example, if you're on a steroid, or if you are in the 5 to 7 years post-menopause, often we'll see the bone density loss show up first in the spine. And then femoral neck, because of Ward's triangle, has more trabecular bone as well. Total hip tends to be later. Again, this is just in general, not always. So we are definitely going to focus on the spine. And how are we going to do that? So program ideas, I started the back. We didn't get that much into exercise because she's already doing the CrossFit. So we discussed a little bit more about alignment and how we're going to progress. So a lot is going to be on education of how to gradually progress with overload carefully. And I'd mentioned that we probably want to order some additional tests, thyroid, P1NP, CTX, things like that. But that, again, she followed up with an MD. I do not order these. And I'm also not a nutritionist. I focus on exercise. But she may want to find a nutritionist who specializes in bone health, who is also understanding of a history of ED. We do not want to overtax our brain with too many restrictions or anything like that. We just want to get the, depending on how her calcium tests come back, calcium and vitamin D levels to a good amount. All right. So I just wrote down some additional notes that I wanted to say. When she first emailed, she found out early onset osteoporosis, and she's a member of a CrossFit gym, but not sure quite how to do the exercises best for her. And then the update was there are back x-rays to see if there's any silent fractures. So that's something we want to keep in mind, and some follow-up tests. So, whew, I'm going to stop the share for a second. Laura, how are you doing?
Thank you.
Is it weird to be talked about on camera like
Yes,
this?
yes, a little. But I really appreciate it. So thank you, Justine.
So, when my patients or clients do a certain exercise program, I like to try it out. So I did try, gosh, several years ago, CrossFit. So I understood what that was. And so I had discussed a little bit with Laura that CrossFit can be quite fast, and you can go to a pretty extreme fatigue level. So in general, we tend to get injured when we're very tired. So I had recommended that she do progressive overload carefully, but not too many exercises at once. So how is that going? Did you return to any of your CrossFit exercises?
I kept going, and partly because it's a really nice community, so I didn't want to leave my friends in a way. But I also like the atmosphere of the gym, very understanding. If you want to go slower or stay at a lighter weight, it doesn't feel competitive, so that's really important to me. So, and I also pick the days that have exercise that I understand are important, like squats that you were just showing, and also deadlifts. And maybe I don't go the day where they're doing some complicated weightlifter movement. So, and I do feel like my strength is growing with those basic weight training exercises.
Excellent, excellent. So CrossFit is does have a nice research showing that is one of the it's a good exercise system to progress rapidly. But again, 100%, you always want to make sure you have a trainer who understands osteoporosis, and especially in Laura's situation, her bone density scores are quite low, and until we get more information, better safe than sorry. So we're going to keep it safe. So let's go to, we didn't get to do this too much with Laura because she already, here we go, has some things that she's already doing, right? So focus again is spine and femoral neck. And so what days are you doing CrossFit?
Typically Monday, Tuesday, and Thursday.
Okay, so one recommendation is I'm going to recommend, so it is important that you take rest days to repair. It helps prevent injury as well. So you said Mondays, Tuesdays, and Thursdays?
Mm-hmm.
So I'm wondering if there's a good class. I know weekends, sometimes it's more crowded and things like that. So if you're going to do Tuesday, if that's what works, you might want to focus more on legs
Mm-hmm.
one day, and then more on upper body, or also known as arms, another day. And then we could do Thursday more of the full body.
Mm-hmm.
Okay, so it's interesting because bones are fabulous tissues. They're incredible, right? If you have, I just had a friend whose son fractured his arm, and in like 6 weeks, it's better, right? It's insane. Bones can repair quite quickly, but tendons take forever. Tendons don't have as much blood flow. They can take like 12 weeks. So really, when we're starting to think about progressive overload, we don't want to just think about bones. We have to think about the whole body and all the tissues, right? So tendons can take a little longer. So you got to give them time to grow and to repair. Okay, so for legs, what are you squatting these days?
A little over my body weight. So I think it's 118, something like that.
Great. And are you doing barbells or dumbbells or what?
Barbell.
A barbell. Okay. So with someone like Laura, who's quite fit already, I would absolutely look at her form. And we're going to recommend not to do overhead presses at this time until we get your fracture assessment back. So what are you doing for upper body?
Mm,
Rows, pull up, you have your pull-ups.
there's quite a range. So definitely the pull-ups. And if it's the right time, I did have a question about overhead movements. If it is an overhead squat, for example, so it's quite stable, you're holding the bar up. Does that put the same, are you concerned about that in the same way you would be with like a quick movement, the press up?
Okay, so Laura, part of the reason I picked Laura is it's a complex, so the best exercise to do is the one you're gonna do, right? And Laura's quite fit already. So, but family history and low bone density, we have to be careful, right? So one of the things with overhead is there is an increased risk of spine fracture with overhead movements. However, one of the big risks is that if someone already has a spine fracture, or many people with osteoporosis also have what we call kyphosis, so they have a rounded upper back. If you have a rounded upper back, the mechanics of the shoulder are thrown off, so you could injure your shoulder as well. Yes, it tends to be more stable if you're kind of press up once from the barbell rack and then you're holding it there, as opposed to up and down, or you're fatigued, or you're but again, we're going to play it safe until you get your fracture assessment score back and until we know a little bit more. I would love for you to get a trabecular bone score scan as well. So the more information we have, the more risk we can take. At this point, I've only worked with you for an hour. So, and another reason is that there's so many other great exercises you can do instead, right? Yes. So if there weren't, other options, then I'd say, maybe we'll do it, but there's a lot of ways to load the spine a little bit more carefully. So I would wait until we get the results back until you do overhead presses.
Mhm.
All right. And then you're going to do the full body. So and then what impact are you doing? You're doing the running.
Right. So usually once a week I run, maybe on Saturday, and then I do also walk back and forth to work. That's about 2 half-hour walks.
Okay, and what day is that? Those are every day, Monday through Friday?
Monday and Wednesday, actually.
Okay. So, so this is going to be a little tricky. So Laura's bone density in her femoral neck is quite low, and yet she's running and walking. So what do we need to do for that? First, I don't always do this, but first I'm going to wait until her strength of her hips go up. And then we're going to work a little bit on jumping and then progress to jumping off a platform. For example, I just saw a woman today, 74, which we'll talk about with Debbie, getting into more of the balance aspect. And we started her with the heel drops. So going up to your tippy toes and dropping on your heels. Then we progressed to small jumps, and now she's jumping off a step stool and then a rebound jump. So it's down and another jump. So that's one way to progress impact. So with Laura, I would probably do some progress to box jumps.
Mhm.
Now, that's because you're young and fit already. If Laura does have a -3 femoral neck, so we would progress very slowly. Often I won't progress for at least 3 months. So I would do maybe heel drops for 3 months and then progress if someone has -3 in their femoral neck. And then also Laura does CrossFit, so I'm not as concerned with balance. I will talk about balance more with Debbie. Do you have any additional questions?
No, I don't think so. And I actually, good questions about what are some good spine exercises. I see them coming up, and I do farmer's carry. So that's interesting to think about what part of the body that might help as well.
Yes, farmer's carry is excellent. So there's a lot of great questions coming up, but I will definitely, Shelley, I'm sure will prompt me. Okay, yeah. So farmer's carry is fabulous. Farmer's carry is when let me stop share for a moment. It's all you're doing is you have to have very good form to pick up the weight. So often what I'll do with people is I progress the height of the weight that's being picked up as well. So you have your hip hinge and your flat back, dumbbells drawing in, and you connect the shoulders, and you hold the weight and you basically just carry it. So you just carry the weight and walk around. So, for example, I had someone today who's I've progressed up to, she's now carrying 30 pounds, so 2 15s. And she's going 400 feet with the 2 15s. So, that may or may not be enough for Laura because she's already lifting 115 pounds. So that is that I do have a barbell that we use, and we progressively overload the barbell, and then people walk backwards and forwards carrying the barbell. We also use kettlebells for our farmer's carry, and that loads the spine and the wrists. So it's really great. And we do want to think about, so I mentioned this briefly, but wrist, spine, and hips are the 3 major fracture sites. So for the spine, to prevent a fracture, we want to avoid flexion and compression. So we want to avoid this rounding, and compression could be lifting something from the floor, so it's pushing me down. Compression could be part of the reason why we're avoiding overhead movement, is there is a little more downward compression on the spine. But we also want to strengthen the spine so that when you do compress the spine, because that's something we do in life, that your body can support that load. So a nice way is to have the weight and feel the downward compression from the arms and the trunk, and you're using your strength to resist that downward compression. So we are training the spine to prevent a compression fracture. So that's absolutely a fabulous exercise that I do ask people to do quite frequently. But that I tend to put that more in the spine prevention.
Another question, Justine, that came in is, does a squat with a heavy barbell place too much weight on your neck? Or could you even place the barbell in front, or not the barbell, but maybe a kettlebell or something in your chest instead of on your neck?
So I'm going to pretend this walking stick is a barbell for demonstration purpose. When you have a barbell, it should not be on the bones of your spine, right? So there's a way to contract the muscles in your upper trapezius to create more of a muscular shelf for the barbell, and your bones of your vertebra of your cervical spine should not be resting on those bones. They should really be on the upper trapezius muscle. That being said, this is quite an extreme position for some shoulders. So there's many options. Yes, you can do a front loaded squat, which also loads the wrists as well. Or you can use a lot of different options. You can use, we had Karen kind of mention that she's keeping the weight close to her center of gravity. You can put the weight on the sternum. You can put the weight close to the seat center, or the center of gravity. And then someone mentioned kettlebells. You can hold kettlebells by your sides. You can do what's called a goblet squat. This is a very light kettlebell. Where you hold it kind of upside down on your sternum, and it's very close again towards your spine. So there's many options. There was actually 2 people that I did the consult with from the support group, and they work once a month with a physical therapist, and I am extremely biased towards physical therapy, so I'll throw that out there. But I see a lot of progress, especially the people I tend to see usually have multiple concerns. Like they might also have knee arthritis, or they also have Ehlers-Danlos syndrome, which is a hypermobility syndrome, or a lot of other risks, spondylolisthesis and other things. So it's nice if you do have some structural concerns that you work and you progress with a PT. It's a really nice way to go. Just a suggestion. Thank you, Laura. Do you have any other questions?
No, thank you. This has been really helpful.
Should we
Good.
progress then? And thank you, Laura. Should we progress to Debbie next?
Yes, we have
Okay.
Debbie now.
All right. So I will just wait a minute. There we go.
All right. Hi, Debbie. How are you doing?
Hello. I'm good. How are you?
I'm good. I am going to share the screen. And what do we have here?
A mess, a chocolate
Oh.
mess.
Oops, wrong one. That's not Debbie. Here's Debbie. Debbie.
Here I am.
Okay. So we have Debbie here. She is 62, postmenopausal. She has a compression fracture at T12 and low back pain. She was 5'5" and now 5'3", so she has had a height decline. And her son passed away 2 years ago. So we also know that a change in serotonin, depression, grief is a risk factor for osteoporotic fracture. Medications, she got 1 infusion of Reclast. And she's been on an anti-seizure medication that they switched her up to a different one, but the one she was on does have some side effects of potential bone loss. And then supplements with vitamin D and also calcium, 300 milligrams a day. So those are the risk factors we want to consider. T-scores, spine, minus 4.5, where we're going to talk about that. Femoral neck is minus 3.3 and total hip minus 2.3. So now this is an example of these additional questions that we have to be a little bit concerned with the DEXA scan because she does have spine, she has a scoliosis, and she has that compression fracture, and she has some spine arthritis. So her DEXA scan scores of her spine may not be as accurate because of these concerns, right? So it might throw off her scores. So often when somebody has several factors in the spine that might make the DEXA scan of the spine less reliable, I highly recommend getting the wrist done so that we have another site to compare. She thinks she may have had a calcium levels checked, and it was normal. No other testing. All right, so strengths. So prior exercise as a child, she was an ice skater and she played a lot and ran track. She also taught ice skating for 32 years and she was a professional ice skater. She performed with multiple professional companies, including Ice Follies and Holiday on Ice. So one thing, around age 65, so a few years from now, I would absolutely focus on balance because at age 70 is the risk for fracturing a hip goes up significantly. And that's regardless of bone density. So anyone approaching the age of 70 should start a balancing program and strengthen the legs. Now, that being said, Debbie has great balance because she's been an ice skater her life. So we again didn't focus that much on balance, but I'm going to show you what I chose for her because of that. So currently, she does about 3 to 5 pounds for hand weights. She stretches daily, she walks, and she still skates. Great. So osteoporosis in the spine, yes, she has that. Now, again, the scores we're not 100% sure on, but she has it. So we're going to avoid curling or flexion for now. And then -3 or less than -3 in the femoral neck. That is also, she has that. So we're going to gradually increase the impact. Motivation, highly motivated to exercise. She is an exerciser and she enjoys it.
Yes.
All right. So
I better.
what was that?
I better.
Right?
Yeah,
After all.
so-
So what did we start with? We definitely want to strengthen the spine. So we started with Rose and her spine is already pretty strong. So we already started with a gray TheraBand. So if you're not familiar with these TheraBands, the TheraBand company has levels. So it starts with yellow, red, green, blue, gray, and then there's also a black. So starting with gray is already pretty strong resistance. And so she will be moving off of TheraBand quite quickly to weights, but we're going to start out with TheraBand. For her hips, instead of a squat, I chose lunges for several reasons. First of all, the squats were way too easy because she's been ice skating for many years. Now lunges, what I like about lunges is it also incorporates balance. So if someone has osteoarthritis or grumpy big toes, I like to say, sometimes lunges are not a great choice because you do have to bend that big toe or modify. But if it's a nice way to incorporate both balance and strength. Another nice thing, if someone has scoliosis, often one leg tends to be stronger than the other. Or if somebody's done kind of an asymmetrical movement or exercises for many years. So lunges can also, you can see the difference between the strength in one leg versus the other. So for example, if you're right leg dominant, you might only be able to do 7 lunges on the left and then 12 lunges on the right. So it would be it's a nice thing to start out with. All right, so we didn't get time to do a wrist exercise, but if she is still skating, which she is, there is a high potential to fall on an outstretched hand, right? So if we're walking slowly and fall, we tend to fall on our hips. If we're walking fast and we fall, we tend to fall on our hands. We kind of reach out to protect ourselves. So we would also want to make sure we get in some wrist bone strengthening. All right, so for her impact, right now she's walking 30 minutes, 4 times a week. So we did a similar thing that we did with Karen, which is we're adding 2 minutes of fast walking. So she's going to do 10-minute warm up, add a minute of fast walking, another 10 minutes, add another minute of fast walking. And then for balance, right now we're doing the lunges. And we're gonna progress next time I see her. I also sent her some videos. We have YouTube videos of different exercises. So I sent her some balance exercises. All right, so for fracture prevention. So again, once we start getting, it's not there yet, but once we start getting to the 65 age mark, we do want to, and with the low bone density in the femoral neck and in the spine, we want to look at some other risks of fracturing. Pets is one risk factor. So if you are running to get the door because someone's knocking on the door and the dog is barking and running also to the door, you do not want to trip and fall over your pets. Posture and lifting mechanics, of course, that's for everyone, but especially for someone with spine osteoporosis. So what we did during our session is I showed her how to keep a flat back, which I'll show you in a moment, with a stick. And we also want to progress her lifting mechanics because she has 2 grandchildren. Yay! So it is always fun. I had someone today come in who is lifting her 9-month-old grandchild without any hesitation because she's super strong now and has great mechanics. And then I asked her to do a little piece of homework. I asked her to look around her house for any loose throw rugs, for any clutter, and make sure there's really good lighting, especially from the bedroom to the bathroom, things that you might need light in the middle of the night.
Good.
So those are some environmental risks that you're gonna check for, because you could have the best balance, but if you trip over something, you trip over something, right?
Right.
Okay, so. Any questions on that?
Hey,
No, I think that's good, but I
go
will
ahead.
make a correction. I'm not a grandparent. I'm a great auntie.
Sorry, great auntie.
Yep, that's okay.
Thank you. Shelley, did you have a question?
No, I thought that was very interesting. And thank you so much, Debbie, for volunteering to do this as well. It was
Please,
so,
my pleasure. Thank you very much, Justine, and really, I hope it is helpful to everybody. Yeah.
So I do, if we have 1 more minute, and then I'm going
Oh,
to take
sure.
questions. So for
Oh,
Debbie,
okay.
what days are you going to do your strength training?
I try for the Monday, Wednesday, Friday, but of course, with some holidays or whatever, there's plenty of other days to do it. So whenever I can get off of the Monday, Wednesday, Friday, or I'll fit it in.
Excellent. So
Whenever-
again, this is our perfect world
Yeah.
spreadsheet. So yeah, we're working on it. So for balance, we have lunges right now, but we're going to add some balance exercises, and you also have homework to check environment.
Yeah, no, that's good. It's already good.
Yay.
Yeah.
Debbie had some experience. How did you said you worked with people to prevent falls in their home or something? You said you had worked with older people in their home.
Oh, yeah, I was a home health care person.
Home
and
health.
Yeah, I did home health care, my little old neighbors, and yeah, they were wonderful. Yeah.
So when I started talking about this, she was like, oh yeah, I know this.
Yep.
And then you're doing your walking. and you
Yes.
added minutes at fast.
Yes, started with the fast pickup pace for a minute and yeah.
And what days are you doing that?
Again, usually the Monday, Wednesday, Friday, but I'll fit it in whenever I can or get an extra day in doing it.
Great,
know,
great.
yeah.
So, so right now, this is her sheet to start with. So again, if you want to make, anyone who's watching want to make a quick chart for yourself, make sure you have your resistance, your impact, and your balance. Balance training is kind of like learning a new language. So I always joke that I tried to learn the guitar during the pandemic online, and I only practiced once a week. So I did not learn the guitar because you know what it's like to play an instrument. You have to practice a lot, not once a week or every week. You're learning the same 3 chords over and over again. So balance is similar to that. It's similar to a musical instrument or a language. You really need to practice every day. It's different than progressive overload. So progressive overload or that resistance training 2 to 3 times a week because you need that recovery time. But balance is more of a neurological system, remembering reflexes. You want your reflexes to go a little bit faster when you're wobbly. So that's something you want to practice daily. Okay, so
Thank you. And thank you again.
yes,
a minute, hold on. Debbie, let me find you because okay. Thank you, Debbie. I appreciate
Yeah, my
you doing
pleasure.
that.
Thank you all.
And Justine, you had a few more questions, and I wonder if would you be able to stay on after
absolutely.
we finish the video? Because I know people don't usually stay that long for the video. So I'm just gonna thank you. Oh, I should have kept you up here. Wait a minute. I want to say for starters, that was great. That was such a unique presentation. Such a unique presentation. I mean, I loved it. It was so educational, and you have plenty of more questions that we'll answer. But I just want to say thank you for being such a great resource. And I know the BHOF is so lucky to have you. You teach all over the world. Um, you know, the wonderful job you do with gyrotonics and physical therapy. And we have you as our wonderful resource. And I just want to say thanks for all the time you put into this presentation.
Thank you, Shelley. And I hope it was helpful and put some clarity into how to design an exercise program for oneself.
I'm sure it has. It definitely has, even for me. I took so many copious, I'm telling you, I've got a whole notebook here. Anyway, thank you. I don't go anywhere. And thank you to our YouTube audience. I just want to say thanks for getting on tonight. And members that are live tonight, stay on and stay tuned. Thank you.